Okay, welcome everybody to today's acid-base clinical case conference. I'm going to be presenting some intellectually interesting but unusual cases today, two of them actually. And the first case is a 55-year-old female who was admitted with an infected knee prosthesis. She had a past medical history of diabetes and obesity. And in the hospital, she was given Norco for pain relief over 6 weeks, and she had some vomiting. And these were her lab values. Of note, her total CO2 on the chemistry panel was 10. She had a slightly elevated creatinine, but her anion gap was 33. And her blood gases showed a pH of 7.44, a PCO2 of 14, and a calculated bicarbonate of 9. So the first question is, what's the acid-base diagnosis? And we use the approach that has been around since the 1960s, really came from Schwartz and Relman's studies. It's called the delta PCO2 to delta bicarbonate approach. And what you do here intellectually is to calculate the change in the PCO2 that the patient currently has from their normal PCO2, and you ratio that to the change in the current bicarbonate to what it should be normally. But, and this would be done for all acid-base disorders, but in this particular case, we do that for acid-base disorders that have a decrease in bicarbonate. And there's three. The first is what everyone would say, the patient has a metabolic acidosis. In that case, you would expect that the change in the PCO2 would be, because of the compensation that occurs, would be about 1.2 for every 1 change in the bicarbonate. Another disorder where we have a low bicarbonate is an acute respiratory alkalosis. And in this disorder, it's the PCO2 that first changes, but we find that the bicarbonate also changes. And in this case, it changes by about 0.2 for every 1 change in the PCO2. And lastly, the third acid-base disorder with a low bicarbonate is chronic respiratory alkalosis. And in this case, for every 1 change in the PCO2, the bicarbonate changes 0.4, or for every 10 change, it changes by 4. So we have the intellectual exercise is to calculate the change from normality. That means you have to know what normality is. Now, we always typically have assumed male numbers with a PCO2 of 40 and a bicarbonate of around 24, but it's been known for many, many years that females have slightly lower numbers for both. The PCO2 is around 38 and the bicarbonate is 23. And since our patient was a female, we'll use that for her normality to calculate the change from normality. So our patient had a PCO2 of 14 and a bicarbonate of 9. So when we calculate the change in PCO2 to change in bicarbonate, we get 24 because the PCO2 fell by 24 versus 14, which is a ratio of 1.7 to 1. And you might think immediately, well, this isn't one of the 3 choices. Well, if you see that, you know without thinking further that you have more than one acid-base disorder present, because if it's a single acid-base disorder, it has to fall into one of those 3 categories. And now we just have to think, what is the so-called mixed disorder, or why is there more than one? Well, the anion gap was elevated, so we can say with some certainty that there was a metabolic acidosis. However, if it was compensated, we should have seen a ratio of 1.2 to 1, which means that for every fall in the bicarbonate, your ventilation changes such that the change in the PCO2 is approximately equal to the change in bicarbonate. It's a little bit more. It's certainly not 1.7 to 1 like our patient. So since our patient had a ratio that was greater than expected, in other words, another way of saying it is the PCO2 fell to a greater extent than normal, our patient, if we're right that there's a metabolic acidosis present, must also have a respiratory alkalosis because the PCO2 fell more than we would predict just from the compensation. So thus far, we have a patient with an anion gap metabolic acidosis, most likely, and a respiratory alkalosis, but we can't stop there. We need to also calculate something called the delta anion gap.
Ira, can I interrupt a second? You haven't told me, or maybe you did in the beginning, what's the pH? Is the patient acidemic or alkalemic?
7.44. Because the PCO2 fell so much.
Okay, so the patient is euhydric.
You can use that term, but the pH ends up from the Henderson equation to be normal just because
Normal,
of
okay.
whatever the PCO, yeah, because of what the PCO2 and bicarbonate are. So we also need to calculate something called the delta anion gap, and this has also been around in nephrology for 30 years or more. And this idea is the following: that when you have an organic acidosis, the organic anion represented by A minus here is made in the cell, but it's made with a proton. It's never made with potassium or sodium or some other monovalent cation. And what happens is there's a distribution of the organic anion going in, some stays in the cell, but some goes into the extracellular fluid. The proton also will leave to some extent into the extracellular fluid, but when it does so, it binds bicarbonate to make water and carbon dioxide. We get rid of the water and carbon dioxide, so we're okay as far as that's concerned. The same reaction with bicarbonate occurs in the cell. I just didn't want to show that for simplicity. But the thinking here is then that for every change in the anion concentration here, the bicarbonate should fall to the same extent. Now, there are assumptions here that the volume of distribution of both is the same, the excretion rates from the body are the same, but given all that, if we assume that the change in the anion gap from its original level is equal to the change in bicarbonate from its original level, we can utilize that information to calculate the original bicarbonate concentration, where the original bicarbonate concentration would equal the current bicarbonate plus the change in the anion gap. Now, as I mentioned, there are a number of subtleties that are associated with that. But ignoring those for now, this gives you a poor man's way of calculating what the bicarbonate was originally. So when we do that in this particular case, the problem always, like the norm, when we say what were the normal acid-base numbers, we don't know what the normal anion gap was in this patient because we don't have a previous admission, but let's assume it's 11 or 12. We take the current anion gap, subtract what we assume the normal anion gap was, and we get a change of 22 from normality. Well, if we use this equation, we can take the 22 and add that to the current bicarbonate, and we end up with a predicted original bicarbonate of 31. Now that's above normality. So we also have to account for why the bicarbonate was 31. And so we have to revise our acid-base diagnosis. And now we come to this conclusion that if the patient had an anion gap metabolic acidosis and a respiratory alkalosis, there must have been another reason for the elevated bicarbonate. So the patient had a metabolic alkalosis, most likely. Now, as far as the clinical course, the Norco was stopped and the metabolic acidosis subsided, slowly corrected over time. So what should be ordered? Well, they ordered a pyroglutamate, and I'll discuss the significance of that. It's also called 5-oxyproline, and the level was 10.5 millimolar. You can get this through Quest. So a clinical diagnosis was made of pyroglutamic acidemia. And what is this? Well, in 1974, Larson published a paper called Pyroglutamic Aciduria as an inborn error of glutathione metabolism in a child. It's a rare autosomal recessive metabolic disorder, usually appearing in infancy. And it's characterized by disability, ataxia, hemolytic anemia, and chronic metabolic acidosis. And it's caused by a marked deficiency of glutathione synthetase activity. Glutathione, remember, is a critically important antioxidant, and it's made of 3 amino acids. It's a linear thiol tripeptide, and it's present at pretty high concentrations in almost all mammalian cells. It's composed of glutamate, cysteine, and glycine. Now, in our patient, it was interesting because this patient was not known to have this before and should have had this, since childhood if it was on a genetic basis. But in 1989, Creer reported in an adult pyroglutamic acidemia, and this appeared to be acquired, and it wasn't clear why, but it definitely wasn't present before. And ketoacidosis, lactic acidosis, methanol, all the other causes of an organic acidosis were ruled out. And the patient had high concentrations of pyroglutamate, or also called, as I mentioned, 5-oxoproline. So the hypothesis was that the patient had an acquired form of this acid-base disorder. Now, a urine screen was positive for acetaminophen, but no association was made with acetaminophen at the time. And the patient's biochemical abnormalities gradually resolved with bicarbonate, the usual therapy, and also empirically discontinuation of the acetaminophen. Now, this is a complicated slide, but it's important to go through because the glutathione metabolic pathway is what acetaminophen is now known to interfere with in some patients. So if you focus here on the top left, glutamic acid, the first of the 3 amino acids in glutathione, is turned into gamma-glutamyl phosphate by this enzyme, gamma-glutamylcysteine synthetase. The same enzyme then adds a cysteine to make gamma-glutamylcysteine. The gamma-glutamylcysteine has a glycine added to it to make glutathione. Now, what happens with chronic high levels of Tylenol use, and in the patient I showed you, if you calculated the Norco administration over 6 weeks, the patient got about 107 grams of Tylenol. Each Norco has 325 milligrams of acetaminophen in it. So there's a lot of acetaminophen given. Acetaminophen binds to cysteine and it's excreted in the urine. And when cysteine drops in the blood, it inhibits this reaction. So the gamma-glutamyl phosphate cannot have a cysteine added. In addition, acetaminophen is converted into this toxic compound called NAPQI. And NAPQI inhibits the addition of glycine in the last reaction. In addition, acetaminophen binds to glutathione also and is excreted in the urine, and this turns out to stimulate this reaction. So what you end up with is this reaction cycling around and cycling around, and you make a ton of 5-oxoproline, which is the pyroglutamic acid. This is an acid that has a pK of about 3.6. It's a quite strong organic acid. So this, as it's made, is going to release protons into the cell, ultimately the blood, and drop your bicarbonate. And this thing just keeps going around and around and around. And it also utilizes up a lot of ATP. So you end up with this futile cycle where glutamate is just reconverted into glutamate, but utilizing up ATP in the cell. And this just reiterates some of the things I talked about. 50% of the acetaminophen is excreted in the urine as acetaminophen sulfate, acetaminophen cysteine, acetaminophen mercapturate. These are all sulfated metabolites. And cysteine stores get depleted, and you end up not being able to make gamma-glutamylcysteine to add that to the backbone of glutathione. It also binds glutathione per se, and that stimulates the creation of that first part, that vicious cycle. And then 5% is oxidized to NAPQI, which binds to glutathione and inhibits the first part of the cycle. The importance of NAPQI is people now feel that's responsible for the liver disease that some of these patients get. It's a very toxic molecule. And again, acetaminophen is oxidized to this compound. So as far as the acid-base disorder, its true frequency is unknown. It's usually associated with long-term acetaminophen use. There has been a rodent model where they just put the acetaminophen in the drinking water. The majority of patients are women for some reason, not well understood, with chronic medical diseases, and it resolves after stopping the acetaminophen. Some people have tried to give N-acetylcysteine, may accelerate the recovery by increasing the cysteine concentration. And in the rodent model, methionine has been tried, likely due to its conversion to cysteine also. Some patients have actually been dialyzed. As far as the risk factors, these are the risk factors in the literature: malnutrition, chronic alcoholism, liver disease, kidney disease, females, and long-term acetaminophen use. Although it's not predictable as to the temporal component or the magnitude of the acetaminophen intake. But it's just something to consider in a patient who's on acetaminophen chronically, who develops a metabolic acidosis with an elevated anion gap that you can't explain. As far as organic acidoses in general, The fellows will likely remember the acronym MUD piles to remember all the different types: methanol, uremia, ketoacidosis. Here's what we just talked about: pyroglutamate, propylene glycol, and then ingestions such as INH, ecstasy, and cathinones, lactic acidosis, ethylene glycol, diethylene glycol, and salicylates. Some people now use this acronym GOLDMARK, same sort of things, just a different way of remembering. The glycols, ethylene, diethylene, and propylene, oxoproline, which is the pyroglutamate, pyroglutamic acid that we discussed, L and D lactate, methanol, aspirin, renal failure, and ketoacidosis. Again, in all of these, you have an organic anion made with a proton, and the proton comes out into the extracellular fluid and binds to bicarbonate to lower it, and the organic anion comes out and increases your anion gap. Again, bicarbonate in the cell is also being decreased. I'm just not showing that for simplicity. So what are the acids? I mean, that's a key question. We know the compounds, but what acids are actually, what organic anion is coming out, and these are coming out with a proton. So with ethylene glycol, probably the most complicated: glycolic acid, glyoxylic acid, oxalic acid. You can see these here. Diethylene glycol, propylene glycol, lactic acidosis. Methanol leads to the formation of formic acid, which is thought to cause the optical abnormalities. INH actually leads to a lactic or ketoacidosis. Ecstasy, lactic acidosis, and cathinones are narcotic-like compounds that also induce a lactic acidosis. So let's go to the next case. It's a 23-year-old female, gravida 2 para 1 A0. She was admitted at 32 weeks gestation because of a low potassium that was resistant to treatment. Past medical history: she had the same sort of thing in a previous pregnancy, or the labor was induced at 37 weeks. She had a K of 2.6 to 3.4 and was noted to be hypertensive. But her K resolved as soon as she gave birth, right after pregnancy, in the previous child. So she came in with the same thing. And on physical, her blood pressure was 131/81. So the first question is was she hypertensive? And this just shows from patients at different times during their pregnancy what the mean systolic and diastolic pressures are. And you could see for someone who's at 32 weeks, you would tend to get these numbers. So she was clearly hypertensive, mildly hypertensive. And these were her lab values. She had a K of 2.5, a normal total CO2 on the chem panel, and blood gases here, which have numbers that look pretty normal. Of note, the K in the urine was 38, and with that creatinine, you can calculate a fractional excretion of potassium of 33%. This represents the amount of potassium coming out in the urine divided by the amount filtered. Normal's around 5 or 6%. So you can say that there's some abnormality here in the nephron, resulting in excessive potassium secretion relative to the filtered load. Her MAG was 1.5, might seem a little low, but the normal MAG in the third trimester is a little lower than in non-pregnant women. The calcium might seem a little low, but again, that falls within what you can see in the third trimester. The normal range is lower. An aldo was measured and it was less than 3. The normal aldo in a non-pregnant female would be 4 to 3 nanograms per deciliter. In the third trimester, it goes up significantly to about 60. So this was really suppressed. And the renin was 2.7, which isn't very low, but in the third trimester, it should be around 14. So it was low relative to physiologically what should have been present. And the patient remained hypokalemic despite potassium and getting chloride, in the form of KCl, with MAG supplements. At 37 weeks, she was induced, and again, the abnormalities resolved postpartum. So the first question is there an acid-base abnormality? I mean, everything looks pretty normal here. The anion gap is normal too. On the face of it, you might just say, well, this patient has normal blood gases. Until you look at, as always, we have to compare it to what normality is, but here normality is what should exist in the third trimester pregnancy. And this is just data from Templeton's old study, but what was done was to look at a large number of women at different times during their pregnancy. And what you can see here is By the 12th week even, the PCO2 is down, as is the bicarbonate. And this is pretty much maintained throughout pregnancy. So the first major changes occur in the first trimester. Our patient should have been somewhere between here with a PCO2 on average of around 30 and a bicarbonate of around 20. And this is what we would diagnose as a chronic respiratory alkalosis, a chronic decrease in the PCO2. We see that in patients who have chronic liver disease or people that live at high altitude like Denver, Colorado. Anyone with a low PCO2 chronically has a decrease in the bicarbonate. It takes about 4 to 5 days to reach a new steady state, but after that, these numbers just stay constant. The initial part here we would call an acute respiratory alkalosis. So we would have expected this person to have a chronic respiratory alkalosis, but there was something here normalizing both the bicarbonate and the PCO2. And it gave us the impression then that this patient has normal blood gases. So the question then is, how could these numbers be normal in the third trimester of pregnancy? And so we're faced with now, if it's true that the patient had a chronic respiratory alkalosis, we have no reason to think she wouldn't have, then she must have also had something raising the bicarbonate and the PCO2 to normal. Remember, the PCO2 goes up in a metabolic alkalosis as a compensation also. So we don't just have an increase in the bicarbonate. And so we would say that the patient had a metabolic alkalosis, and we know it likely was chloride resistant, not from having measured a fractional excretion of chloride or a chloride concentration in the urine, but because we were giving the patient chloride as KCl and nothing happened to the bicarbonate. So what are the findings in our patient? The patient had hypokalemia, the aldo and renin were suppressed, the patient had hypertension for what she should have had in the third trimester of pregnancy, and a chloride resistant metabolic alkalosis. So what's the diagnostic syndrome? Well, the diagnostic syndrome is pseudo hyperaldosteronism. It's pseudo because the aldo is low. So what are the causes of pseudo hyperaldosteronism? There's Geller syndrome, apparent mineralocorticoid excess, Cushing syndrome, Crusoe syndrome, glucocorticoid remedial aldosteronism, Little syndrome, and congenital adrenal hyperplasia. And for the rest of the talk, I'll be going through all these diseases. So in our patient, what's the most likely cause? Well, it appeared to be associated with pregnancy and resolved right after the patient gave birth. So there's something going on in pregnancy that's not going on after the patient had a child. And the diagnosis most likely is Geller syndrome. So what is Geller syndrome? In 2000, Geller published a paper in Science called Activating Mineralocorticoid Receptor Mutation in Hypertension Exacerbated by Pregnancy. So what is going on here? Well, I'd like to review briefly what's happening to the mineralocorticoid receptor. So what's the mineralocorticoid receptor? The mineralocorticoid receptor is a receptor that binds aldosterone, and it's expressed in the nephron in the distal portion, the second portion of the DCT, which stands for distal convoluted tubule. It's also in the connecting tubule, and it's also in the cortical collecting tubule. The receptor now is known what it looks like at the atomic level. It has 12 helices. Helix 12, 10, and 3 are responsible for binding aldo, which is shown here. Little hard to see, but if you look at this yellow-green structure, that's aldosterone. And then when aldosterone binds here, the receptor leaves in this case, the basolateral membrane of these cells, goes into the cytoplasm, goes into the nucleus, and then binds to different genes in their promoter regions in what are called hormone response elements, and then induces changes to the expressions of those genes. So what are the transport functions stimulated by aldosterone? Again, another way of asking it is what genes in the nephron, what transport genes have aldosterone with its receptor bound to their promoter regions. And these are some of the transporters. I didn't put all of them for simplicity reasons, but ENaC, sodium channel, we'll talk about it a little bit. the ROM-K potassium channel, the vacuolar proton pump, and the anion exchanger A1, it's because aldose stimulates the expression of all these proteins that you end up with a chloride-resistant metabolic alkalosis with hypokalemia. So what about this syndrome? Well, steroids like aldosterone has a 21 hydroxyl group that activates the mineralocorticoid receptor. Steroids without the 21 hydroxyl group normally do not. So for instance, progesterone does not bind to the wild type receptor, again, found in this region of the nephron. But these patients typically have an S810L activating mutation in the mineralocorticoid receptor. It turns out aldo works completely normally. And unlike the normal receptor, even when there's no hormone present, this receptor actually can stimulate these genes with about 27% of maximal activity. So it's always active, even in the absence of any hormone. But importantly for these patients, progesterone activates the mutated receptor, especially by the third trimester when its concentration significantly goes up in pregnancy. Progesterone never binds to the mineralocorticoid receptor normally. And it's the progesterone then which is driving these transporters and not aldo. Important in these patients to remember is don't give aldactone. Aldactone actually stimulates the mineralocorticoid receptor in these patients and will make things worse. So the other question is, how does this occur in males? They don't get pregnant, but there is constitutive activation. And also in all males, there's a hormone called 7-hydroxyprogesterone, and it's thought that 17-hydroxyprogesterone can bind to the mutated receptor. At least that's one explanation, because you can see this in males too all the time who have the mutation. What about apparent mineralocorticoid excess, the next disease? Well, that's due to a decrease in an enzyme called 11-beta-HSD2. Now, in order to understand what's going on here, it turns out that there are tissues that have this first enzyme, 11-beta-HSD1, and then there are other tissues like the kidney, colon, and salivary glands that have 11-beta-HSD2. Now, in the ones that have this enzyme, these tissues have a lot of cortisol in the tissue, and they create the cortisol from cortisone, which is inactive. It doesn't bind to the glucocorticoid receptor with any great affinity, but the cortisone is converted to cortisol where it's active. The kidney has the opposite. The cortisol that's near the tubules is converted to cortisone, and that's because cortisol has the same affinity to the mineralocorticoid receptor as aldosterone. There's no difference. They both bind with equal affinity. And the other important thing is that cortisol is about 1,000 times higher in blood. It's in the microgram per deciliter range, whereas aldo is in the nanogram per deciliter range. So there's a ton of cortisol outside those nephrons, and cortisol would then be able to bind to the mineralocorticoid receptor and constantly create a hypokalemic metabolic alkalosis. But it's because we have this enzyme normally, the 11-beta-HSD2, that cortisol is converted into the cortisone. And so we never have by the mineralocorticoid receptors a high cortisol level, preventing this from occurring. But in these patients, they have mutations in this enzyme and they cannot convert cortisol to cortisone. So they're constantly activating the mineralocorticoid receptor with cortisol. So what are the features? It's autosomal recessive. It tends to occur in pediatrics. They present with hypertension, hypokalemia, metabolic alkalosis. For some reason, they get hypercalciuria also and nephrocalcinosis and CKD. It's not well understood. Maybe from the volume expansion, not clear. To diagnose the patients, they have an increased ratio of urinary free cortisol to cortisone. The normal is about 0.3 to 0.5. They can have a ratio of 6, 7, or 8. They have much more cortisol because it's not being metabolized to cortisone, not just in the kidney, but those other tissues also. Genetic testing really is the way to go now, where you get a diagnosis. The treatment is with mineralocorticoid receptor blockers, or ENaC blockers, such as amiloride or tramtarine. We'll talk about ENaC a little bit later. And some clinicians give glucocorticoids to suppress ACTH, which will then suppress cortisol. But in general, the glucocorticoids are not needed. Now, there's an acquired form of inhibition of this enzyme, and it has to do with this root, Glycyrrhiza glabra. So what is going on here? Again, this is an acquired form. These patients don't have any mutations in the enzyme. Well, it turns out licorice is part of the story here. So licorice contains glyceric acid, shortened to GZA, which when it gets into the intestine is hydrolyzed by certain bacteria to glutatidic acid. And the glutatidic acid absorbs and inhibits, is a potent inhibitor of this enzyme. And it's now thought that the safe upper limit is about 100 milligrams per day of GZA, or about 2.5 grams of licorice. Now, it turns out that GZA is now absent from most licorice produced in the US, but it still can be found in other countries, and it can be found sometimes in flavored chewing tobacco or imported licorice. The licorice is added to give it a sweet flavor. It turns out also that some agents that are used to antifungal agents such as itraconazole and posaconazole are very potent inhibitors of this enzyme too, and there are a number of cases reported who get the same acid-base disorder. And again, once you stop these compounds, everything goes away. The diagnosis is an increased cortisol to cortisone level in the metabolites, which are sometimes measured in the serum or urine. And the treatment is MR blockers. Ultimately, you stop the licorice. What about Cushing's syndrome? Well, Cushing's syndrome sort of falls into the same thought process. And there's no problem with these enzymes. It's just so much cortisol is present that the enzyme can't keep up with it. The enzyme is just, there's not enough enzyme active to turn the cortisol into cortisone. And so you end up with the same sort of thing as if you didn't have the enzyme. But it's obviously dose dependent. So patients that have Cushing's with less cortisol won't have as much of a problem. But again, it's because cortisol binds to the mineralocorticoid receptor with equal affinity to aldosterone. Now, what about Croce's syndrome? In 1982, Croce's in the JCI described a syndrome of primary cortisol resistance in man, a glucocorticoid receptor mediated disease. So what he described was patients who had mutations in the glucocorticoid receptor. So you can just think conceptually, in that case, cortisol can't act. So in a normal person, we have this complicated scenario where we have corticotrophin releasing hormone with some AVP is here just for simplicity, and the hypothalamus releasing ACTH from the pituitary. And then when the adrenal gland sees ACTH, we tend to think of ACTH only affecting cortisol, but ACTH also can stimulate androgens, and there also is some stimulation of these mineralocorticoids, deoxycorticosterone primarily. Now, what happens in Croce's syndrome, where you don't have the mineralic or the glucocorticoid receptor working properly? Well, what happens is everything just backs up and tries to compensate for the abnormality. So the CRH is high, the ACTH is high, cortisol goes up. You also, though, as part of the syndrome, secrete more androgens, so they have children have ambiguous genitalia, all these abnormalities that you can see here, and also in the mineralocorticoid pathway, deoxycorticosterone is made, which is a potent mineralocorticoid also, and has the same affinity to the mineralocorticoid receptor as does cortisol and aldosterone, and you end up with hypertension and a hypokalemic chloride-resistant metabolic alkalosis. So again, the clinical features, it's autosomal dominant. It's known now to be mutations in the NR3C1 gene. This is the gene that codes for the glucocorticoid receptor. Again, it's a pediatric disorder with hypotension, hypokalemia, and a metabolic alkalosis. And these children are viralized with the other abnormalities that I showed on the previous slide. The diagnosis, they have a significantly increased serum cortisol or urinary free cortisol. You give them dexamethasone and they have abnormal suppression. Typically, the test is done by giving 1 milligram of dexamethasone between 11 and 12 midnight. And then the next morning, you measure the cortisol, and it should be less than 2 micrograms per deciliter. And because the whole axis has been stimulated and they have the receptor abnormality, the cortisol stays high. And genetic testing is obviously the definitive way to know what's going on. Again, the treatment, similar to before, MR blockers or ENaC blockers, amiloride or triamterene. Some people have tried long-term high-dose dexamethasone up to 3 milligrams a day. It takes long-term and a higher dose because the axis has been so stimulated for so long, then to shut it off doesn't occur acutely. You're trying to suppress ACTH, but by doing so, if you're lucky, you'll be able to suppress not only the cortisol, but also some of the androgen production and the deoxycorticosterone, the mineralocorticoid. Now, what about this disease, glucocorticoid remedial aldosteronism? This is a separate disorder that also leads to to pseudohyperaldosteronism. So to understand what's going on here, we have to go to chromosome 8, which has these two genes pretty close to each other. One is the aldosterone synthase gene, and the other is the 11-beta hydroxylase gene that we talked about before. And what happens in these patients is they have a crossing over, and they actually form a third gene, which doesn't normally exist, that has the promoter for 11-beta hydroxylase. This promoter, by the way, is strongly stimulated by ACTH, but the coding region is the aldosterone synthase gene. So they have this chimeric gene now where the aldosterone synthase is actually stimulated strongly by ACTH. So this is just going a little deeper. Now, this is the normal adrenal gland. And remember, there's actually 3 anatomical regions. The outermost region is the zona glomerulosa. That's where the mineralocorticoids are made, such as aldosterone. The zona fasciculata is where the cortisol is made. And not shown here below is the zona reticularis, where the sex steroids are made. Now, normally, is in the zona glomerulosa, where you have the mineralocorticoids being made, you have stimulation by angiotensin II and potassium. And ACTH, although it does stimulate a little bit the mineralocorticoid pathway, most stimulates cortisol production in the zona fasciculata. But in these patients, they actually have an extra gene, an extra chimeric gene in the cortisol producing part of the adrenal gland. So they have the normal 11-beta hydroxylase gene responsive to ACTH, so they make cortisol, but now they've got this hybrid gene, this chimeric gene, where ACTH can actually stimulate aldosterone production. And because of that, aldosterone production in the zona glomerulosa is really suppressed, mainly because angiotensin II is so suppressed. But it also turns out, as I'll mention, potassium fails to stimulate aldosterone secretion in these patients, interestingly. So what are the clinical features? First, it's autosomal dominant. Again, a pediatric disorder with hypotension and a hypokalemic metabolic alkalosis. Interestingly, because ACTH has a circadian rhythm, aldosterone from the zona fasciculata is only stimulated part of the day. Just like cortisol, there's a diurnal variation in cortisol secretion, highest in the morning. And so you tend to find the aldo high in part of the day, and it can be normal the rest of the day, usually high in the morning. So it really depends when you make the measurement. Potassium can be normal in these patients, especially in the afternoon or at night, because the aldo is normal. So they have this fluctuating acid-base disorder and electrolyte disorder depending on what the ACTH levels are, which is really not seen in the other conditions, and that's a clinical clue. As I mentioned, angiotensin II and potassium do not stimulate aldosterone secretion in these patients. For some reason, they have increased hydrochlorothiazide sensitivity. It's not clear whether this is unique to this group of patients. It could be because their volume expanded and there's more of an effect of hydrochlorothiazide in these patients. There's nothing from a molecular level that should cause the sodium chloride cotransporter to be more sensitive in the distal convoluted tubule in these patients. It's likely something to do with their volume stat, although it's not clear. It's just an empirical observation. And also, there's a number of cases reported that have cerebral aneurysms, like in polycystic kidney disease. Again, it's not clear whether this is unique for GRA and why it occurs. But there are a number of case reports. So the diagnosis here is an interesting one, and that is when you give dexamethasone, you can actually suppress the aldo production, which you tend not to see in normal people, and also genetic testing. The treatment, you typically give glucocorticoids at bedtime because what you're trying to do is suppress the morning ACTH spike. Again, the morning is when you typically see the hypokalemia and the other findings as far as the elevated blood pressure. As the day goes on, things tend to get a little better. And also MR blockers work in these patients. Now, what about Little syndrome, another disease that causes pseudohyperaldosteronism? Well, Little syndrome is caused by heterozygous mutations in the beta or gamma subunits of the epithelial sodium channel. That's the acronym. ENaC stands for, or ENaC is the acronym, which result in a truncated C terminus in these proteins. So the epithelial sodium channel ENaC is not one protein. It comes from 3 separate genes. And there's an alpha, a beta, and a gamma gene. They encode 3 different proteins that associate in the apical membrane of certain segments in the nephron. They have each have 2 transmembrane regions and a large extracellular loops here. What happens in Little syndrome is that depending on where the mutations are, they're typically in the cytoplasm and the C terminus. The C terminus isn't encoded because of the mutation. And it's usually a stop codon mutation or what's called a nonsense mutation. And so you end up with a slightly shorter protein. It still functions though. But what is the problem then? Why do these patients have a disease? Well, first let's back up a little bit and talk about where ENaC is and what it does. Remember, ENaC is in the same region of the nephron as the mineralocorticoid receptor is. It's in the distal convoluted tubule. Again, the second half of the distal convoluted tubule. It's in the connecting tubule and the collecting tubule. And what it does is it transports sodium from the lumen here, the urine side, into the cell. When it does that, it increases cellular potassium secretion, not shown here, but it's on ROMK. It's not the same protein. There's another protein that now secretes potassium into the lumen. And protons are also secreted on a totally different cell, which we won't get into today. The reason for that is there's current loops between these 2 cells due to sodium uptake that changes the electrical membrane potential on the second cell. In addition to that, because there's a change in the transepithelial voltage, which means from the lumen to the outside, chloride is transported paracellularly between the cells on claudin 4. The bottom line is that when ENaC works, you end up with enhanced sodium absorption, enhanced K secretion, enhanced H secretion, and enhanced chloride absorption. And you can predict, everything you're going to get. You're going to get hypokalemia, you're going to get a metabolic alkalosis, and you're going to get volume expansion and hypertension. So what is Little syndrome? As I mentioned, Little syndrome is caused by mutations in the beta or gamma subunit, not the alpha subunit, which truncates the C terminus in the cytoplasm. But importantly, these mutant ENaC proteins no longer have a binding site for what is called E3 ubiquitin ligase NADD4-2. Many proteins are degraded by being ubiquinated. And there's an enzyme that's needed to ubiquinate this particular transporter and other transporters. But you have to have the binding site present on the transporter for this enzyme to work. And the mutation actually prevents this enzyme from binding. And that leads to significantly less degradation of ENaC. So these patients have much more ENaC on the plasma membrane. They have less of a turnover. It doesn't affect the function. It just is a lot more ENaC. So the result is inhibited breakdown of ENaC, leading to increased expression, and I would add function on the apical membrane. So they have enhanced sodium absorption, enhanced H secretion, enhanced K secretion, enhanced chloride secretion, leading to the clinical phenomenology. So this is an autosomal dominant disorder. It's in children again, same sort of thing, hypertension, hypokalemia, metabolic alkalosis. Nowadays, genetic testing is what's done, and the treatment is to block ENaC with amiloride or tramterine. Mineralocorticoid receptor blockers are ineffective in these patients. It's important to remember, because the problem is not in the mineralocorticoid receptor. As long as you have ENaC hyperfunctioning, this isn't going to do much. Now, what about congenital adrenal hyperplasia? Congenital adrenal hyperplasia, there's two that I'll show. This is the first, and this is a complicated slide, but this is a breakdown of all the compounds made in the adrenal gland. Again, thinking about it anatomically is the easiest, where on the surface of the adrenal gland, you have mineralocorticoid synthesis in the zona glomerulosa. In this middle part, you have glucocorticoid synthesis in the zona fasciculata, and the androgens and estrogens are made in the innermost part in the reticularis. Now, this enzyme, and of course, we need ACTH and cholesterol to create all these compounds. These patients have an abnormality, have mutations in this enzyme, and this enzyme is shown here in the orange arrows. So when you don't have this enzyme in the zona glomerulosa, you block the production of mineralocorticoids to aldosterone. You do, though, still make deoxycorticosterone, which is an important mineralocorticoid, and that's going to be important to remember. So there's a lot of this around, and this acts just like aldo. They can't make cortisol. They have a lot of deoxycortisol, but deoxycortisol doesn't bind well to the glucocorticoid receptor. And then everything here gets shunted over to here, so they have a lot of testosterone made and estradiol. So this pathway is excessive. So they lose this, and this is shunting to here. So you can sort of predict what's going to happen. It's autosomal recessive, again, the same phenomenology, but they're viralized because they have too much testosterone. They have high basal and ACTH stimulated. Cosentropin is a synthetic ACTH stimulated 11-deoxycortisol, and they have a very low cortisol. So remember, 11-deoxycortisol is converted to cortisol by this enzyme. So they have a lot of this and little of cortisol. And the 11-deoxycortisol is metabolized, so you can measure this metabolite in the urine also, again, with low cortisol excretion rates. And genetic testing is one way to go. The treatment is with glucocorticoids to try to suppress ATH, or use in combination MR blockers and ENaC blockers. And this is the second enzyme, 17-hydroxylase deficiency, that can cause pseudohyperaldosteronism. Here, the orange bars are okay, but the green bars represent this enzyme. So this pathway is perfectly fine. You make deoxycorticosterone, the important mineralocorticoid. Aldo should be made properly, but you're missing all this, so you can't make cortisol, and you don't make the sex steroids normally. So these are patients who have an autosomal recessive disorder, the same sort of thing metabolically, and the loss of androgen in males and estrogen in females is what you find. You do an ACTH stimulation test, and ACTH stimulation test, the goal is to give about 250 micrograms of ACTH, and then 30 minutes later, you measure the cortisol level. It should be over 20 micrograms per deciliter, and these people can't make cortisol. But they do have high DOAC and corticosterone with low cortisol. The DOAC is what causes all this, the hypertension, hypokalemia, metabolic alkalosis, and the corticosterone is high too, and it actually is a good glucocorticoid. So they tend not to be Addisonian in these patients, even though their cholesterol is low. and genetic testing is the way to go. So some people give glucocorticoids, although it's not absolutely needed because corticosterone, as I mentioned, is a potent glucocorticoid. DOAC, which is the deoxycorticosterone, is inhibited by giving the glucocorticoids. So that's one reason people try to do it. Although you can give MR blockers and empiric sex hormone replacement. And finally, there's an acquired form of this disorder. You may have heard of this compound, abiraterone. It's now used for therapy in castration-resistant prostate cancer. And Jason recently had an acid-base case where the patient was on this, one of their quiz cases. So it turns out it's a selective, irreversible inhibitor of this 17-alpha hydroxylase, and also this additional enzyme in the adrenal gland, both of which are required for androgen synthesis. But again, you end up with the same acid base and electrolyte phenomenology because it results in the accumulation of DOAC. And as I said, corticosterone is also made. So that's a potent glucocorticoid. You tend not to see the effects of the low cortisol, even though cortisol is low. So the DOAC causes the hypokalemic metabolic alkalosis. And corticosterone, as I said, has glucocorticoid activity. So adrenal insufficiency is prevented in these in people who are on this compound. And because it occurs in almost all cases now, the clinical guidelines are it's approved only for use with glucocorticoids. Now, you're not allowed clinically to give this alone. You have to give a glucocorticoid, and the goal here is to suppress ACTH activity, which will ameliorate the disorder. Obviously, if you can stop the drug, that's the best thing to do. But it looks exactly like 17-alpha hydroxylase deficiency. So just to recap, there's many causes of pseudo-hyperaldosteronism, especially for the fellows. And the treatment for a lot of these is the same. The diagnosis now, historically, we used to measure a lot of different metabolites, adrenal metabolites. Now, the typical approach is to try to determine what the mutation is. Now, the assumption whenever you do genetic testing, since you're not doing whole exome sequencing or intron and exon sequencing, is that the patient will have the mutations that have been described in the literature. And that may obviously not be the case, not just for this, but for any genetic testing you do. But assuming, your particular patient has a mutation that's been described and the company is measuring that mutation, you'll get back a positive result. But the lack of a positive result or the lack of a mutation doesn't mean that it doesn't exist. And so if it's unclear, you have to do further testing, measuring different analytes in the blood and the urine, or doing different stimulation or suppression tests. And with that, I'll stop, and I'd be glad to take any questions anyone might have.